And just want to welcome everyone. We still have a number of people who are signing on at this point. We have about 125 people on now. And we're going to present only for hopefully around 20 minutes and give opportunity for people to ask the questions that are on their mind, particularly around vaccine. So I'm going to give a short update. Natalie, if you go to the next slide. This is what we're going to cover. I'm going to give a short COVID-19 update for the hospital, really to give you some context for how truly difficult this pandemic has been at the hospital. And then Dr. Neeley is going to spend another 10 minutes talking about COVID-19 vaccine. And then hopefully, as I said, we'll be able to answer any questions that you have. Next slide. So just by way of background, from what we understand, people who get a COVID infection, first of all, we want to say it's not like influenza, unless you're referring to 1918. It's in most cases an asymptomatic infection. And for those who are symptomatic, about 80% have what we call mild disease. They might be a little short of breath. But for the most part, they're able to oxygenate their blood, and they're not so short of breath that they have to run to the hospital. But about 20% of people have what we'll call severe disease involving the lungs and requiring some oxygen support because of abnormally low oxygenation levels. And then about a quarter of those people end up in the ICU on a ventilator with organ failure. You know, the overall mortality rate is a little over 1% for anybody who gets in a COVID infection. And when we say that, you know, everybody's like, well, 99% chance I'm going to get well. If you have open heart surgery at St. Joseph's for triple vessel disease, the mortality is about 1%. How many of you want to line up for that? So it's when you think about you get an infection that is very easy to get and 1% of people die, this is a very serious infection. And people who are saying, well, we don't need a vaccine because it's not a very severe infection aren't thinking right. 21% of all the patients hospitalized, a little over 21%, actually die at the hospital. So if you're sick enough to get admitted to the hospital, about 21% of patients are dying. And then if you're sick enough to be on a mechanical ventilation in the ICU, the mortality is about 50%. So that's the numbers that we're seeing. Those are the numbers that have been published across the country. And if you're over 50, and Dr. Neeley's got a great slide for the sliding scale of age, or if you have these comorbidities of hypertension, diabetes, obesity, cancer, chronic lung disease, or chronic heart disease, your chance of dying or your associated mortality is much higher. And then the other kind of not so great news, I like when Dr. Neeley, I joke with him a lot about all the different treatments he talks about, because we go through all of them, we provide all of them, and all of them have some marginal benefit for certain types of presentations. But the most effective actually is just using steroids for people who have a highly inflammatory process going on in their lungs. And that's something we've been doing for a couple of decades or more. Very inexpensive treatment turns out to make the most difference for a subgroup of patients that are the sickest. Next slide. In other words, we don't have very good treatment. So when you get this, it's not like we have an antibiotic to give you and we're going to give you a cure. These are our actual numbers at St. Joseph's, inpatient data only. So it's really important. We test a lot of people here preoperatively, otherwise asymptomatic folks. This is for people who are sick enough to get admitted to the hospital. We've had almost 2,000 unique cases as of yesterday morning or midnight the day before last. And some of those patients were readmitted, about 147 were readmitted to the hospital. 466 deaths, including I think the mortality in January was about 130, and the mortality in December was about 100, just at St. Joseph's. And again, our overall mortality, 21.9%. Yesterday, we had 81 COVID positive patients in the hospital, including 31 of those in the ICU. During this pandemic, we've had as many as 154 COVID positive patients in the hospital on December 24th. And we've had as many ICU patients between COVID and non-COVID as 88 ICU patients. We have 39 licensed ICU beds. And again, you can see the breakdowns of age. About 57% of patients are 61 or older. I think the most interesting slide is the one at the bottom right-hand side, which basically just shows you the weekly admissions to the hospital. And the good news is that trend line is going in the right direction from the second and third week of December being a peak of 136 admissions in 1 week. Next slide. This is the county's numbers yesterday, and it shows the only thing to get out of this is ICU capacity. So the hospitals are at 130%, 137% of ICU capacity. That's being driven by San Joaquin General and St. Joe's. The other hospitals, when they're at 90% or 110%, it's one patient. But in our case, when we're at 149%, it's almost 30 patients, or excuse me, it's almost 20 patients. So again, very big difference. And San Joaquin General, actually, their ICU is the busiest for their bed capacity. Next slide. And this just shows the COVID positive patients on the top line for the whole county yesterday. And if you go down to the third line, 70 of those patients in the ICU. You go to the fourth line, 62 of those patients are on mechanical ventilation. And that predicts a mortality of around 30 of those patients. Just do the math on what I already told you. Next slide. This just shows where San Joaquin County says we are on the tiers. It's a little confusing because the state says we're in tier 1 of tier 1B or phase 1B, which would mean that education, childcare, food and agriculture, a whole bunch of other categories are qualified to give vaccine. But so far, when we're directed by county public health, we're pivoting from phase 1A to give to people 65 years and older. We have very limited vaccine, but we're trying to vaccinate about 200 new people a day who are part of our physicians' practices in our community that are 65 or older. Next slide. St. Joe's by far has cared for the most COVID positive patients, about 40%. We've cared for about 44% of the ICU patients countywide. And as I said, we've expanded our ICU bed capacity from 39 to 70, and then we overflow from that into the emergency department as well. We began vaccinating our hospital employees and medical staff, then community physicians and their office staff, so that medicine can be available to everyone in the community. And then we were asked by County Public Health to do public safety. And so we've done Stockton PD, the probation department, and other police departments of universities or colleges where they needed to have help. And then again, we've extended vaccine to the San Joaquin Quality Care Network, a group of our physicians for patients that are 65 and older, while supplies last. And I think that's kind of an underscore as the state is going to change their approach to allocation to hospitals like us or other vaccination sites that can receive vaccination or vaccine to something that's more like mass vaccination. We'll probably get a chance to be involved in that. And that probably will happen around March 1st. Next slide. So Dr. Neeley is our Chief Medical Officer. He's also our designated institutional official for our graduate medical education programs here. I like telling Dr. Neeley's educational background because he went to Harvard for undergrad and then he went to Stanford for medical school. And I like to make the comparison, and that's where the comparison between Dr. Neeley and I begins to separate. So with that, let me turn it over to Scott Neeley.
Thank you very much. And it's good to be here today. Thank you, Mr. Wiley. I'm Scott Neeley, and as Mr. Wiley said, I'm the Chief Medical Officer at St. Joseph's Medical Center. A little bit of my background, I'm trained as a pulmonary critical care physician, and I actually spent 25 years in clinical practice as an ICU specialist, caring for the very sickest patients in the hospital as sort of my daily routine. And so as we face this pandemic, I'm seeing something that is on one hand familiar, but on the other hand is like nothing I've ever seen before. Some of our very, very sickest patients with COVID-19 have an absolutely horrendous form of lung disease, the likes of which people like me with many years of experience have seen, a number of times in our life, but nothing like what we are seeing now. I might see one of these type of patients a few times a year in my busy private practice in Chicago 10 years ago, whereas right now we probably have a dozen or more of these just extraordinarily ill patients in our ICU right now. So this is like nothing we've ever seen before, and I think that when people think about comparing it to an influenza epidemic or something of that nature, it's important to understand that there are no real comparisons in any of our lifetimes to what we're actually seeing now in hospitals really across the United States. So let's go to the first slide. Talking about vaccine, we're talking about the single intervention that has a hope of ending the pandemic and ending the type of just extraordinary severe illnesses that we're seeing in hospitals across the country. And yet, many people still have a lot of questions about the vaccine, still are wondering whether getting a vaccine is the right thing for them. And we wanted to look at some of those concerns and questions during this presentation today. People are concerned, for example, that the vaccine was rushed, that it was not tested well enough, that it might have a lot of side effects, or even that they could actually get COVID from the vaccine. There are folks who are thinking that they might be better off actually getting the infection and developing natural immunity versus getting a vaccine, or that the vaccine might somehow change the DNA, the genes in their cells. So we wanted to talk about some of these issues and also have time for questions today. So let's go to the next slide. One of the most important things I'd like you to take away today is that the risk of actually getting the COVID infection is by no means trivial. And as we get older, that risk becomes very, very significant. It is true that most young people have mild disease, but the overall risk of death, as Mr. Wiley already mentioned, is 1 in 100 people who get the infection. And that is actually a very high risk for such a contagious disease. It's essentially like nothing we've ever seen during our time. And as we get older, that risk increases substantially. For example, just being over 50 years of age, your risk of dying if you get the COVID infection is 30 times higher than somebody who is in their mid-20s. Excuse me. If you're over the age of 65, your risk of dying is actually 90 times higher than somebody in their mid-20s should you get the infection. And that number more than doubles again if you're over the age of 75. So older people and people with comorbidities such as diabetes, obesity, heart disease, have a very, very substantial risk of dying from this disease if they get infected. And it's certainly nothing that anybody wants to take a chance with, but particularly if you're in the older half of the population or you have some underlying medical problems. Next slide, please. Now, this slide actually goes into some of the details of how the two currently approved vaccines were developed, how they work, and how they were tested. The bottom line is these vaccines were developed by some extraordinary scientists who had enormous financial backing in order to fast-track a technology that had been developed but had never been developed successfully into a vaccine before. It's a very simple, it's a very directed technology, and I'm not going to go into details now, but if there are questions, we could talk more about that. The two vaccines were tested in over 70,000 participants in two very well conducted trials. And the vaccines both turned out to be extraordinarily effective at preventing infection and also extraordinarily safe with an extremely low number of adverse consequences as a result of the vaccine in these two trials. Next slide, please. So this is just some information that comes out of the Pfizer study. And these are the two groups, the placebo group who did not receive a live vaccine and the test group who actually did receive the live vaccine. And you can see that the placebo group, designated by the red squares, had a nice steady increase in the number of infections seen in the group after day 0, or the day that they received their placebo injection. On the other hand, the group that got the vaccine had a few infections between days 7 and 21, the period of time between the first vaccine and the booster on day 21, and they only had 9 total infections in the group after that 21-day booster. That amounted to a 95% reduction in the risk of getting the infection, and nobody who got a vaccine had severe disease. All of these cases of infection in the vaccine group were mild disease. So the vaccine was extraordinarily effective and also extremely safe. There were no severe adverse events seen in either one of these studies. And that is the safety data with which we moved forward with administering the vaccines. So what do we know now? We actually know a lot more, because now over 33 million vaccine doses have been given in the United States. Now, there have been a few incidences of severe allergic reactions. The incidence of severe reaction has been about 1 in 100,000 vaccine administrations. So 1 in 100,000 doses has resulted in a severe allergic response, and that's defined as somebody who actually needed to be treated for the allergic response. That would be giving somebody epinephrine typically. Nobody who has received the vaccine has died in a manner attributable to the vaccine. So none of these allergic responses have actually resulted in death. Now, when you contrast this to a 1 in 100 chance of dying by getting the natural infection compared to a 1 in 100,000 chance of an allergic response with a 0% chance of dying if you get the vaccine, it's a pretty easy decision to make in my book. The other thing about getting the vaccine is it also decreases the spread of the virus by decreasing mild and asymptomatic infections in recipients. So the virus can't spread if people aren't getting the infection. If you think getting the infection and developing natural immunity is somehow a reasonable alternative to getting a vaccine, think about the fact that you're actually allowing the virus to continue to spread if you get that natural infection. You're also providing a substrate for the virus to mutate, and we can talk a little bit about some of these new strains that have developed, but the mutations, the strains develop as a result of the virus having a chance to continue to replicate and spread. So stopping the virus with vaccines is the safest thing for an individual. It's also the safest thing for all of us. Current versions of the vaccine do seem to provide at least partial protection from the variants that have been identified, and so it is still strongly recommended that people get the vaccine as soon as they have an access to it. Next slide, please. Our attitude is this is about staying safe together. The most important thing that we can do is get a vaccine, but we have to continue to use the practices which are highly effective in limiting the spread of the virus, such as wearing a mask, physical distancing, and hand hygiene. This is incredibly important, both the vaccine and the other measures that we can take, because slowing the spread of the virus is what is necessary for us to get back to business, to get our schools open, to get our businesses open, to get the economy working again in a way that can sustain employment, and to protect our healthcare institutions. We are inundated with patients, and we're having to operate in a very different manner as a result of the pandemic. We don't want that to put people at risk, whether they have COVID or whether they need us for another reason. And we have to protect our healthcare institutions by limiting the spread of the virus and clamping down on the pandemic. The new normal means safe care for all of us. It means having the resources that we need to take care of COVID patients, but it also means preserving our resources to take care of everyone who needs health care. Next slide, please. One thing that we have been focused on like a laser, even during the course of this pandemic, is safety. We want to make sure that people get great care and that they're safe while they're doing it. And what we've been able to accomplish during this period of time is to continue to reduce the risk of medical error and to continue to reduce the rate of harm to people as a result of medical errors. And that's what this graph shows. That's what that downward line shows, that we're continuing to not only meet the extraordinary challenge of this pandemic, but to actually improve care and to keep people safe while we're doing it. Next slide, please. We talk about having one purpose at St. Joe's, and that is a purpose that's shared by every single one of our employees, every single one of us who works here, every single one of our physicians and providers, and that's exceptional care with dignity and human kindness. And that's what we're striving for every day. We're so proud to be able to serve our community. I do think we have time for questions. We went maybe a few minutes farther than we wanted to, but we're here.
Relatively speaking, Dr. Neeley, that was tremendous. So that was very, very good. We do have a problem with time sometimes. But yep. Dr. Neeley did a great job giving a very simple version. He can talk for like 10 minutes just on the protein coding for the vaccine. So we could get into that if you want to. You know, a couple of questions that we had ahead of time, and one of our former employees asked, is there a chip technology or a tracking technology included in the vaccine? I don't really know how to answer that other than I think I'm already being tracked by my phone and my computer and everything else, but to our knowledge, obviously there's no tracking mechanism. But what do you say to somebody who says, you know, I have less than I had more than a 99% chance of survival if I'm 50 years or younger, even if I get the disease? Isn't the vaccine too risky? And a short answer is good.
Short answer is good. I've personally taken care of and met with the families of people who are in their 40s and either going to be severely disabled for the rest of their lives or actually die of this disease. And it is a profoundly serious disease, and it is a profound tragedy that's happening in our country right now. You don't want to take any chance whatsoever of getting this disease. Your chance of dying is significant, almost no matter what age group you're in. But in addition to that, people who get this disease sometimes have very significant long-term consequences, and it is best avoided. The other reason to get a vaccine is to protect other people, protect your loved ones. You might if you're a young person, you may and likely will survive this disease without serious consequences. But your aunt or your uncle or your mother or your grandparents may not, should they get it from you. And you might not be able to prevent them getting it from you if you have an asymptomatic infection, which is how the disease spreads. So getting the vaccine is very important in terms of saving your own life, but it's also very important in terms of protecting those we love and getting our community back to normal.
And Dr. Neeley, did you get vaccinated?
I did.
All right.
I'm a frontline provider. I was very, very fortunate to get a vaccine, and I'm extremely grateful, and I'm going to make sure everybody I love gets one.
Thank you.
I have just a very simple question about severe allergic reactions. And as we move more to mass vaccination and more clinic moving people through, how soon after you get the injection is it possible, if you've had a previous anaphylaxis, to develop an anaphylaxis? How much time, and how are they going to manage, hopefully, monitoring those high-risk people in a clinic format?
Okay. People who get, to begin with, the risk of anaphylaxis is extremely low. It's the incidence that's been observed so far is at 1 in 100,000. Okay. Now the standard procedure for us is to observe people for 15 minutes after vaccine administration, because the vast majority of serious allergic responses occur immediately. That's a characteristic of anaphylaxis. So watching someone for 15 minutes after the vaccine is going to handle the risk of anaphylaxis. I have another question here that's interesting because I've actually been asked this question before and researched it. There is a question as to whether one should get the vaccine if they've previously had Guillain-Barré. And let's expand that to any type of autoimmune disease. Folks who've had Guillain-Barré as a form of autoimmune disease, there are many other types of autoimmune diseases. Autoimmune diseases, including Guillain-Barré, are not a contraindication to getting the vaccine. And in fact, if you look at influenza, which is a vaccine that people oftentimes associate with a concern for something called Guillain-Barré, which is a nerve disease, the risk of getting influenza increases your risk of Guillain-Barré disease more than getting the vaccine. So that is not a contraindication to getting a vaccine.
And Dr. Neeley, during the study, they did have a few people who had symptoms of the Guillain-Barré, but it didn't occur in a higher percentage than what would occur in the normal population of people not receiving any vaccine or anything else for that matter. So it really was no different than the general public.
Yeah. I got a question about a mortality in Placer County as a result of the vaccine. I don't have any confirmed report of that. I'm not familiar with that.
Dr. Neeley, the news came out and the Sheriff's Department apologized for for comments that might indicate that one was linked to the other. He had the vaccine and then he died, but he also has some other things going on. So they did not say it was related to the vaccine.
Okay, well, thanks for that, Natalie. I wasn't aware of that event.
Natalie, you had a couple of other questions. Could you bring those forward?
I have a lot of questions and I'll try to kind of, group them together. One question is there truth that the vaccine can cause infertility in women? Is there truth it can cause brain damage? Those are a couple that I'm going to group.
Okay, we can answer both of those very quickly. There's no evidence whatsoever that it causes infertility in women, and in fact, while it hasn't specifically been studied in pregnant women, a number of women actually became pregnant who were in the original studies, and there were no ill consequences of that. There is no evidence whatsoever that the vaccine causes brain injury, brain damage, or any other serious ailments at all.
Another question is, if you've never taken the vaccine, how would you know if you have an allergic reaction to it? And one kind of similar is, what about if you know that you have food allergies?
Food allergies are not related to allergies to the vaccine. The concern about allergy to the vaccine would be if you'd ever had a serious reaction to another type of vaccine, because the thought is that people who have allergic reactions to the vaccine are having an allergic reaction to a compound that is in the diluent, the liquid that the vaccine is suspended in. There are very low concentrations of compounds that are used to preserve the vaccine in the diluent. It is likely that when people do have a serious reaction, they're actually reacting to one of those compounds. So if you've had a serious reaction to a vaccine before, you should consult with your physician before getting the COVID vaccine. Food allergies are not considered a contraindication to getting the COVID vaccine.
Don, I don't know if you can hear me or not.
Yes.
First of all, thank you. For those of you who don't know, Don serves on the executive committee and the business council and has just done a tremendous job. And you think of all the service that the Dignity gives to our community with its 3,000 employees and the financial impact, and having somebody like Dr. Neeley on staff, how important it is. And so just thank you so much. One of the questions I hear about is how long will the vaccine last? And once you've been vaccinated, can you still spread it? And the same question is once you've had COVID, can you still spread it?
In terms of how long the vaccine lasts, there is good reason to believe that the protection from the vaccine is likely to be sustained for at least 6 months and probably longer. But we will get more information about that as time goes on. There is data to suggest that if you receive the vaccine, you are less likely to be able to spread the illness, but it is likely that at least in rare cases, people who've had the vaccine can get a mild case of the infection and still spread it. The data on that is just very incomplete.
And one of the things that you're also talking about is, once you're infected, for how long can you transmit the virus? And it's very confusing. We've gone through a lot in the last year to try to figure out what the science really is, and the kind of testing that we do, PCR testing, actually picks up the viral RNA, whether the virus is replicating, meaning still able to actually cause harm, or whether it's just dead virus particles, essentially. The equivalent is probably not really considered that. What we started doing in the hospital, just to give you an idea, in the emergency department, if we have a person who tested positive 20 days ago and had a mild illness, we don't consider them to be even needing testing, nor do we consider them to be positive if they were tested, because at this point they've had a low-level clinical infection, and that's really relatively new, but it's on the CDC site and something that you could read about on your own in I think pretty understandable language. But the point really is, you could have someone keeps testing themselves and they keep testing positive, if they've had no clinical symptoms for 10 days, if they had a mild condition, 20 days if they had a severe infection, then they're not likely to be considered infectious. So it's very hard for people to understand that, but that's an easy way to sort of give a guideline on it.
Dr. Neeley and everybody, if allowed, I have some information to share for signing up for registering for the vaccination.
Yeah, go ahead, Mr. Petty.
It's Supervisor Tom Petty. So today at 1 o'clock, if you go to www.sjready.org, our county is launching a new vaccination sign-up program that we created for those that are interested in registering to get the vaccination. The software program is interactive. We'll be able to send you messages and scheduling opportunities so that people can be in the queue instead of kind of waiting and wondering, when's this going to happen? And as you all know, we're held hostage by the amount of vaccinations we're getting, which is in the low numbers, 2,000 to 3,000 per week. And the county is ramping up for large scale events, as you know, through partnerships, Don, as you noted, and everybody's geared up for it. So we're waiting to get those 20, 30, 50,000 vaccinations per week. And we will be able to have staged events throughout the county. So appreciate all the work you guys are doing. We're excited about the sjready.org website. We created a software instead of waiting for the state to do it. We did it right here in our county. So it's great news. You can sign up and not wonder if when your tier is going to come up, because we'll be able to interact with you and give you scheduling information.
Thank you very much, Don.
That's great information. Thank you.